now I am going to invite Dr. Elankumaran Pasupathi. His introduction is that currently he is the joint treasurer of All India Ophthalmological Society. He is a very big very much. He has been a RP Center alumni, chairman scientific committee, secretary of Karnataka Ophthalmological Society, Bangalore Ophthalmological Society. He is a very good orator and a cornea surgeon. So he is going to talk on cataract surgery in post-keratoplasty patients and other challenging situations. Sorry?
Sir, if only I had the powers, I'll do that, sir, definitely. At the outset, I would like to thank Dr. Subhash Prasad, sir, for giving me this opportunity to address such an august gathering. Topic today is cataract surgery in a post-keratoplasty eyes. Cataract, the incidence of cataract is higher, almost 25% in the first 5 years if it's a penetrating keratoplasty, thanks to the manipulation that we do, thanks to the steroids that we use and the inflammation that happens. So there's almost 25% of patients undergoing penetrating keratoplasty invariably end up with some kind of cataract. And it's challenging to do this surgery because most of them present like this, and it is quite fast once the cataract starts. So it's an intermittent cataract. There can be a rhexis runoff. There can even be an Argentinian flaxen. So you have to be very careful. And the point to be noted is these eyes are soft. They've lost their stability. So doing the surgery, not only creating the rhexis, even doing the surgery is also hard in these patients. Add to this, usually these are younger patients, prone to more inflammations, and particularly if it's a penetrating keratoplasty, that gives, if it's a penetrating keratoplasty, the chances of complications with the cataract surgery is much higher. In a lamellar keratoplasty, we can easily get away with a cataract surgery. Now, how are we going to tackle these cases? Well, 5 important points to be noted. Number 1, when do we time this surgery? When should we have it? Number 2, how do we calculate the IOL? The rest of the 3 things, wound construction, endothelial protection and post-operative care, I'll be talking along with the video. Now, when do we time this surgery? Number 1, it has to be a stable wound. What do we mean by this? Anyway, we are going to watch these patients over a period of years. So keep watching after removing the sutures, whether the astigmatism is stable. The change is not more in 2 subsequent, it's the same in 2 subsequent readings. Make sure, if possible, make sure, unless it is intermittent, make sure that all the sutures are removed. Wait for at least 6 months after removing the sutures. Look for a stable keratometry, take those 2 readings and then decide whether to operate. Now the question comes, what kind of lens, what kind of IOL to use? Look at these central readings. This is just for looking at it. Now you have fair amount of astigmatism but looks stable. So the central 3 millimeter reading, if it has regular astigmatism or almost regular astigmatism, then you can think of a toric IOL itself in these cases. However, if the central topography is irregular, then we have to go for a 2-staged procedure. What does this mean? First, stabilize that surface by doing a refractive surgery and think about then doing a cataract surgery. Again, we have to wait for at least 3 to 6 months before we go for the 2nd stage surgery. So point to take home, operate always on a regular cornea. Now, so 4 things to be considered: regular astigmatism, stable cornea. There should also be good endothelial count. So track this endothelium, get a specular count done and then go ahead with it. Always, a cataract surgery in a penetrating keratoplasty is a double-edged sword. With that said and done, let's see how the surgery goes about. Almost, there are no sutures. Regular astigmatism, so has been, sorry, something is wrong. Wrong video is playing it. There's a wrong video which has been connected. The next slide is not playing. Okay, I'll just talk about the thing. Can I connect my laptop, sir? Or time is there?
Go ahead. Connect.
sutures have been removed. Toric marking is done because the central part was regular. Toric marking was done. The placement of the IOL is noted. Then look at the incision as posterior as possible, definitely on the host area, also as posteriorly as possible because the stability of this cornea is not so good. Sometimes we might have to end up suturing. By noticing that bleeding, we know that we have gone towards the posterior limbus. And then as regards the viscoelastic, best is the soft cell technique. Do an adequate capsulorhexis, which is not very large, not very small, because these lenses have to stay in the bag. Difficult if you put it in the sulcus, and later on if you try to, if the graft fails or something like that, difficult to change it. Rest of the procedures are always same, but make sure that the phacoemulsification is always done in the capsule. In the capsule as much as possible, never in the anterior surface. As much as possible, slow parameters, taking care not to damage the endothelium, neither the posterior capsule, and then we can go ahead with the implantation of the IOL. Post-operatively, two things to be considered. Higher amount of steroids, it's not just the 4-3-2-1 what we follow. Typically, first day, second hourly, then 6 times a day, 5-4-3-2-1, and tapering should be very lower. Look for any inflammation because these are corneas which are prone to rejection as well as failure. Failure normally you can see in the first 2 days itself because of the endothelial thing, or while withdrawing the steroid, there is a chance of rejection. So to take care of that, slow tapering of steroids, and the second thing, abundant use of topical lubricants. That has to be done. Now this is one case where if at all, if you find some opacity like this, it's always better to combine DALC along with cataract rather than just do a DALC in these cases. Here cataract has been done and then the DALC surgery has been completed. Why is this? When we do a DALC, the posterior part, what we leave about is hardly 50 to 60 microns, maybe less than 100 microns. And if when we are trying to do phacoemulsification, particularly if that is slightly more complicated, there's a chance that the phacoemulsification can pull in the posterior lamella. This is the reason for that. Now finally, this is not my video which I'm going to play now. This is Dr. Sunil Tangraj's video. What I wanted to show here, definitely SICS has a big role in penetrating keratoplasty also. Look at the posterior incisions. I was told in the corneal incision it has to be posterior, and any doubt it has to be sutured. SICS definitely can be done in these kind of cases, but always take care to look pre-operatively for any problems and post-operatively have the proper. So points for success: stable cornea, remove sutures, or if there is a problem, do it in 2 stages. There should be no inflammation. If it is 2 stages, refractive correction, at least 3 to 6 months later, cataract. Dispersive viscoelastic, soft cell technique. Most important is that communication. Tell the patient there's a chance of failure or rejection and they may require subsequent treatments later, and post-operatively look out for rejections. Time is very important here to be successful as well as to give satisfied patients. Thanks a lot.
Thanks, Alan. Always treat to see your presentations. Very nice presentation. Just wanted to know, in your experience, how many patients did you encounter any case of corneal graft rejections after doing a very uneventful cataract surgery? Do you have any experience of that?
Sir, more than corneal graft rejections I've had, at least 3 of them. But most important, what I want to talk about is one patient where there was a recurrence of herpetic infection after cataract surgery, and in the end we ended up losing this eye. In fact, he had not brought in documents saying why this cataract surgery was done, and in a post-keratoplasty eye, we don't know the sensations there. I had finished the surgery and I had assumed that this is a rejection, and I had given him methylprednisolone. And then the melting started. We couldn't save that patient's eye. This also we have had, sir.
Sir, do you recommend going for preoperative corticosteroid in cases of, not for viral anesthesia, but
For other cases, yes ma'am, but when there is no, these are not like uveitic cataracts. Many of them, like why sir asked this question was, the point to be taken is, most of these patients with the available viscoelastic and the surgery, what we do, they do very well, exceptionally well. Rejections are very, very rare. That's the reason sir asked this question. So pre-operative use of steroids, as of now, we are not doing it, madam. As of now, we are not doing it.
So, yeah.
Slowly. First, post-operative, yes sir, definitely.
And intraoperatively, I think the go slow should be the norm. It should not be very much fast as your usual case, and use of chondroitin sulfate is must, I think.
Definitely,
Yeah.
sir. Dispersive.
So,
Thank you, sir.
yeah, one question from out.
About the steroids, sir, I want to know if you're operating a known case of viral keratitis who went under keratoplasty and then now you're doing a cataract surgery. Those cases also, are you going to start him on tablet Oseltamivir or
As of now, we are not doing it. As of now, we are not doing it. But one point to take home, in those patients who would have noted it down after this incident, and we have to closely follow them up and not push this kind of steroids what I gave. I had given him a pulse dose actually. That was a mistake. No, antiviral, yes sir. Antiviral. No, we don't start. I answered that question. The antiviral definitely knows. We are not starting.
it should be started if there is a history of viral
Do you start in the prophylactic dose or in the 5?
Sir, prophylactic normally, because when doing cataract surgery in known case of viral keratitis, we do start patients before 1 month. We do start them on tablet Oseltamivir, and then after 1 month we do the cataract surgery. So it should be. Is it the norm in case of post PK in viral keratitis for doing cataract also?
Post PK we don't. In case of viral keratitis, what you are telling is right. But post PK, well-healed infection, well-healed, no infection, no inflammation, I don't think there is a.
And sir, you talked about
Basically, there should be loading dose, just maybe 1 week before or maybe 3 days before, and then you can taper to 400 milligram.
there are certain sectors where they recommend this. The one prior to surgery start IC54 milligram.
Loading dose, and then you can taper. Basically, you can continue for at least 6 months.
After the cataract
If
surgery.
you are giving prophylactic.
And sir, another question. You said about two-stage surgery. In cases of where the Myers are not regular, to first go for refractive surgery and then the cataract surgery. What is your preferred refractive
Surface ablation. Surface ablation.